Hello everyone. Continuing the series of solving previous question paper. In Jan 2025, paper 1, the 7th question was asked about enteral versus parenteral nutrition in critically ill patient. So overall the question was about nutritional support in a critically ill patient. It is one of the very important concept even in day-to-day practice, because we deal with many ICU patients in which nutrition plays a very important role. So we will discuss it today. Mainly in introduction, you have to remember a few things. One is, whatever nutritional support we are giving, nutritional support is a very crucial organ support measure for critically ill patient. We have to follow some proper steps when we are considering nutritional support. So in those steps, first thing is resuscitation of the patient. Resuscitate the patient. Patient admitted for any particular condition has to be stabilized hemodynamically. So once the patient is stabilized hemodynamically, we have to start nutritional support as soon as possible. So start nutrition support as early as possible. And if the individual is malnourished, poorly nourished individual, we can start early nutritional support. So this is the first thing. Then we have to calculate ideal body weight of the patient. So there are numerous formulas to calculate ideal body weight, and it is impractical to weigh the patient when he or she is in ICU. So what we will do is, based on the height, we can get the ideal body weight. For a rough measure, just remember that for each 1 feet of height, consider 10 kg as body weight. So suppose the individual is 5 feet, approximate body weight, ideal body weight will be 50 kg. Little bit lesser in females, for example some 45 kg if female. So this is the ideal body weight. Then comes calculation of the required calories. So required calories. Again, here we can consider rule of 25. So just remember 25 kilocalories per kg body weight per day is the required calories. In this one, 25% should be from fat, 25 to 30%. Other 75% should be from carbohydrates. What about proteins? Proteins should not be utilized as source of calories, because proteins are very essential in any critically ill patient. So usual protein requirement will be 0.8 to 1.2 gram per kg per day. So you can give this much amount of proteins. So this is about calorie calculation. Here in calories, one important thing which we have to remember is, suppose the individual is poorly nourished, malnourished individual. When we are beginning the nutritional support, we should be giving little bit less calories, because to avoid refeeding syndrome. So what happens is, in these individuals, if we give surplus of calories, there will be intracellular shift of potassium, magnesium and even phosphate. So all these things will lead to their low level in the plasma, leading to even cardiorespiratory arrest. So we have to be careful in case of malnourished individual. Reverse thing is applied for obese or overweight individual. Give more calories than this usual required or calculated one. More calories for overweight. So this is about third one. calorie calculation. What about vitamins and micro elements, micronutrients? Fourth one is vitamins and micronutrients. These should be supplied every day according to RDA. So this is the thing. Then coming to fluid and electrolytes. Fluids, just remember that 1 ml per calorie. So suppose the individual is of 50 kg ideal body weight, calorie calculation will be 25 into 50. So this will be 1250. So kilocalories per day for him. Similarly, he has to receive 1250 ml, 1.25 liter of fluid per day. This is a simple calculation which we have to follow. Electrolytes, it depends upon the patient's condition and it requires regular monitoring. So once we have calculated all these parameters, now how to choose the route of administering nutritional support. So next point is route of administration. Route of administration. We know that we can prefer enteral or parenteral. That was the first part of the question. So we will discuss the differences between enteral and parenteral. So here one side we will mention enteral, one more is parenteral nutrition. We know that this enteral nutrition is very easy and convenient method, and it is of low cost and safer compared to parenteral, with lesser metabolic complications and lesser risk of infections. All the things will be opposite in case of parenteral nutrition. And one more advantage is here, through enteral route we can maintain the integrity and survival of gastrointestinal tract, mainly enterocytes. Whereas if we are only giving through parenteral route, gastric mucosa will be suppressed because of non-utilization. So that is the one more important consideration. So from this, it is imperative that enteral route is preferred over parenteral. But when to consider parenteral route? When the individual is having some GI abnormalities like intestinal obstruction or mesenteric ischemia, like that. Or if the individual is not tolerating enteral feed, so not tolerating enteral feeds, okay, or if the individual is not expected to be having oral intake in next 3 to 7 days. So if unable to take orally in next 3 to 7 days. So in these situations we can prefer parenteral route. Now coming to the method of giving enteral nutrition mainly. So here patient should be in a position such that head elevation to 30 to 45 degree should be done first. After that, through various routes like NG tube, nasogastric, even nasojejunal tube, what we will do is we have to give continuous feeds. Prefer continuous over bolus feeds. So continuous in the sense every hourly we should give minimum 25 cc, 25 ml of feed per hour. Slowly we can increase this one to 50 to 75 ml per hour. So it should be like every hourly, not giving huge quantity as bolus at large gap. That should not be preferred ideally. Then what we have to do is we have to monitor for we have to monitor for the tolerance of this enteral feed. So what we do after 4 hours or 3 to 4 hours, after 3 to 4 hours, just aspirate and see. Aspirate the content using syringe and see if the residue, gastric residue, if it is more than 300 ml or more than 1/3 of given quantity, it is considered as intolerance. So for this case, initially we can try with some prokinetic medications. For example, IV metoclopramide can be tried. So that will help in the good motility. Prokinetic agent will help in good motility and the tolerance will improve. Suppose the individual is having intolerance symptoms. So what are those intolerance symptoms? Suppose this residue remains more than 300 ml and obviously it will lead to gastric distension, bloating, abdominal discomfort, vomiting, abdominal cramps, even diarrhea. So if these features are there, we have to consider stopping enteral feeding because of intolerance. At that particular point, we can choose parenteral route. So in parenteral, again, you can give it through peripheral line or central line. Again here the cost will be low, but the mechanical side effects will be more in case of peripheral route. So in this one, side effects will be usually related to the mechanical thing, that is IV line site, phlebitis or infection, all those things. And again, infection are common here, and metabolic abnormalities, mainly electrolytes and acid base, will shift over very rapidly in case of parenteral nutrition. So this is the comparison. Coming to some special considerations according to the disease proper when we are giving nutritional support. So some special considerations are like this. In case of respiratory failure, prefer low carbohydrate to fat ratio mixture, because this will lead to lesser production of carbon dioxide, lesser CO2 production, which will be helpful for the patient. Then if the patient is a renal patient, always take care of fluids, electrolytes and protein. So these should be monitored carefully by repeated serum electrolytes, volume status assessment, etc. In case of liver patient, like liver injury, prefer low volume, low sodium diet. And the usual claims of restricted protein in case of hepatic encephalopathy or utilization of branched chain amino acids are not supported by clinical trials. So it is individualized. Next, if there is ARDS, always prefer supportive IV glutamine and omega-3 fatty acids and antioxidants. ARDS and even severely ill, because especially this IV glutamate or glutamine has proven to decrease the length of ICU stay as well as has mortality benefit. So we can consider giving glutamate. So these are some important considerations. And one more thing is, especially in burns and trauma patients, along with all this nutritional support, glutamate should be added. So these are some special considerations. So this is a brief idea about nutritional support in critically ill individuals. Hope everyone got the points. You can note down the points which I will be mentioning in order for easier understanding as well as to revise them properly. Hope you are getting the content very well, please like and subscribe to our channel and share it among your friends so that we can reach even larger number of audience. Thank you so much. See you in next video.